Welcome back. Today we'll be discussing Chapter 29, which discusses trauma to the head, neck, and spine. And once again, you might notice that this PowerPoint kind of looks a little different than the ones that we've done previously in class. This is coming from the 14th edition of your textbook, and I picked the 14th edition instead of 13th for this one, just because there have been a lot of updates in the past couple years regarding how we actually do spinal mobilization. So this has the most updated guidelines in it. So that's why the presentation will be a little bit different aesthetically than what we're used to. So, as usual, we're going to start out with a little bit of review of our nervous system and our skeletal systems. Then we're going to talk about head injuries, neck injuries, and finish out with spinal injuries. So, our nervous system, as you know, it's what controls our sensations and our motor movements, really. Without a functioning nervous system, we won't be able to feel or move things. So, it is very vital to life. Because if we sever our nervous system and we can't communicate with certain muscles, then we can't tell them to do actions of life. So you can divide the nervous system into two different categories. You have your central nervous system and your peripheral nervous system. The central nervous system is your brain and spinal cord. So just those two things, that's it for your central nervous system. The peripheral nervous system is everything else. So any type of nerve that is not directly the brain or spinal cord is your peripheral nervous system versus your central is just the brain and spinal cord. Nerves have something called neurons. And they're the specialized cells that will transmit impulses throughout the body. So you do need your neurons functioning in order to actually move the electrical impulse through your nerves. So that's a little things to keep in mind, but the big thing to take from this slide is central versus peripheral nervous system. You do have to know the difference between those two. Here's a little picture found in your textbook of the nervous system, and the central nervous system is in red, so you can see it's just the brain and spinal cord, and then the peripheral is in green, and you can see that kind of spans your entire body. So we do have two different types of nerves. We have the sensory and motor nerves. So sensory nerves carry messages back to your central nervous system. So it's coming from, say, you touch something hot with your hand. The impulse will go from your hand to your spinal cord and then to your brain, and that's a sensory nerve. That's why we feel that's hot. Motor nerves are exactly the opposite. It goes from the brain to wherever your body is. So say we touch that hot object, you have the sensory nerve carrying to the brain saying it's hot. Brain then sends a motor nerve back down saying let go or get away from it. And so that's how our nervous system kind of works in conjunction with each other. One thing to keep in mind is motor nerves kind of cross themselves when they get to your brain. So your right side of your brain actually controls the left side of your body, and the left side of your body is controlled by the right side of your brain. So they do get crossed on the way back up. So if you have someone who has a stroke that it's in the right side of the brain, you're actually going to see the deficits on the left side of the body. And same with traumatic head injuries. If you have destruction of organ tissue to the right side of the brain, you might have deficits seen on the left side of the body. So keep that in mind that it does work opposite. So I know we just talked about the central nervous system versus the peripheral nervous system. There's also two other things that you need to know about for nervous systems. You have your autonomic nervous system and your somatic nervous system. Your autonomic nervous system does things automatically. These are things that we don't have control of. So, for example, your heart beating. You do not have control over how fast your heart beats consciously, usually. And that's part of your autonomic nervous system. So it's directly from your central nervous system to the organ. We have no control over that. The somatic nervous system, on the other hand, is everything that we can control. So these are nerves that will go to your skin and muscles and will cause you to do what you want to do. So keep that in mind. We have the central nervous system, the peripheral nervous system, and we also have the autonomic nervous system and the somatic nervous system. So those are four things that you do have to know, and you have to know the differences between all of them. So going back into a little bit of anatomy and physiology of the head, if you remember, the skull is made up of the cranium and the facial bones, as we talked about in anatomy and physiology. The cranium does have several different plates to it, or bones. So you have your frontal bone, your parietal, temporal, and occipital. If you don't remember what those are, definitely look back in your textbook and look at the diagrams of these, and or go back and look at the anatomy and physiology presentation, where we kind of go much more into depth for all of these. Broad strokes purposes as EMTs, the different bones in the cranium doesn't really affect what we do all too much, but they are important to know and to be able to discuss things at a educated level with other healthcare providers. And then going in your facial bones, you have your mandible or the jawbone, your maxillae, your nasal bones, the molars, and the orbits. And again, we discussed all those in anatomy and physiology. So if you're uncomfortable with those terms, go back and either look at that in your textbook or watch the presentation. So for the most part, your head doesn't have many joints in it. We want to keep things relatively in place with your head. The exception for that is where your mandible and your skull, meet up. You do form your temporal mandibular joint. My apologies on that one. And that's a hinge joint. That's what allows us to talk effectively. It allows our jaw to go up and down to let speech happen. But without that in consideration, we really don't have many places in our head that move. And there is a reason behind that, because we don't want the things protecting our brain to move and possibly expose our brain. So, things to keep in mind. So, we should all know that the brain is in the skull at this point. Something to keep in mind is the spinal cord does come out of the skull. It leaves the base of the brain through a hole called the foramen magnum, and that is a term that you are going to need to know. It's oftentimes tested on. And also, cerebral spinal fluid is what surrounds the brain and the spinal cord. It's what provides some shock absorption, a little bit of nourishment, and it also helps get waste products out. And that is very important for us to know, because if we see cerebral spinal fluid leaking out of someone, then that's an indication that we have somehow breached the container that's supposed to be in, which is usually your skull or your spine. So if you do see cerebral spinal fluid, that is a very, very bad sign. And cerebral spinal fluid is a clear fluid. So the best way to actually test for cerebral spinal fluid is if you have an area where you might have a route to the brain, such as your ears or your nose or possibly your mouth, and you have blood coming from it. You can put a gauze pad to the blood, take it away, and if you see a ring of clear fluid that forms around the blood, that's probably cerebral spinal fluid. So that's the best way to test for it, and it just means that we have had a breach somewhere in the skull or spine, which is a very, very, very bad thing to have happen. So this is straight from your textbook. This is the diagram that I was talking about a couple slides ago. If at all you are unfamiliar with any of these bones, definitely pause and take a look at them, and or go back to your textbook and get a very good understanding of all these. These are all mandatory for you guys to know at this point. So as we know at this point, the spinal cord is critical for life. It's what all peripheral nerves come off of. So if we have a disruption in our spinal cord, we can't get messages out to our peripheral nervous system. One thing to know is at the bottom of the cord is a segment called the cauda equina. There are some issues that can arise in the cauda equina. Relatively rare, but it's something to know. If someone says that they have problems with their cauda equina, know that it is the last part of your spinal cord. Let's talk about meninges for a second. I'm sure you guys have heard of meningitis before. Meningitis is inflammation of your meninges. So this is something that we are going to need to know about. It's a very tough and fibrous substance, and it surrounds the spinal cord inside of the spinal column. its main purpose is to protect your spinal cord from trauma. And so it does have a few different layers to kind of pad the spinal cord to keep it safe. And these layers are listed as PAD. So if you think that it pads the spinal cord, that's a good way to remember the 3 different layers. So the 3 different layers is your pia, your arachnoid, and your dura. And the pia is your inner layer, your arachnoid is your middle layer, then your dura is your outer layer. But again, if you think pad, that's how you can kind of remember pia, arachnoid, and dura matter. Usually the only time that we think about the meninges is when we have meningitis. And meningitis is when everything gets inflamed from either a bacterial or viral infection. Some symptoms that you'll see with meningitis is a fever. You might have a headache, and definitely a stiff neck is a telltale sign. If you have a headache with a stiff neck, that's very concerning for meningitis. And then photosensitivity is another sign that you might see with meningitis. So this is something that we can't accurately diagnose in the field as EMS providers, but if you have a patient that has all these complaints, be highly suspicious of meningitis. Take some extra PPE precautions because it is caused by a bacterial or viral infection, so we don't really want to be spreading that around to us. So as we've discussed in anatomy and physiology, our spinal column has 33 vertebrae. Vertebrae are interlocked and they are held together with many ligaments and the back muscles. So if the back muscles and or ligaments give out, that's where we could have some injury to our vertebrae, which is typically very painful and can cause chronic lifelong pain. So we do separate our vertebrae into 5 areas. Once again, this should be a review at this point. You have your cervical, thoracic, lumbar, sacral, and coccyx. Your cervical is the first 7 vertebrae, so that's your neck. It's what we call our C spine or cervical spine. We'll talk about that a little bit later. Your thoracic is the next 12, and that's where our ribs come out of. So if your ribs attach to it, then it's in the thoracic area. Going down further is your lumbar, which is the next 5. It's in the middle of your back, and it's the last grouping that can move independently. After that, you have your sacral, which is your next 5, and your coccyx, which is your next 4. Your sacral and coccyx are all fused together, and they form the back or posterior part of your pelvis. So when you feel down your back, when you get past your lumbar, you're going to feel kind of a broader area, and that's because the pelvis is starting to connect to the spine, and that's where you have your sacral and coccyx. And the coccyx, another term for it, is your tailbone. You can usually feel that right at the very lower end of your back. It's a little bony protuberance in a lot of people. And there is no spinal cord in that area, so it's just vertebrae. So no spinal cord actually sits in your coccyx. Here's a diagram that shows all these. There are 2 different cervical spines sections that you might want to be aware of. You have your atlas, which is your first cervical vertebrae, and then your axis, which is your second cervical vertebrae. As far as in the real world treatment, knowing atlas and axis isn't the biggest deal, but again, you might see a test question asking what the atlas or axis are. I personally won't test you on that, but the state might. So vertebrae have many different parts to them. I could talk for probably a half hour about the anatomy and physiology of just one single vertebrae. But things that I want you guys to know is their spinous process, and that is the back of the vertebrae, and that's what we can actually feel when we are palpating down a patient's back, is you're feeling the spinous process. So that's the part that kind of sticks out. Next part that I want you guys to know is the vertebral foramen, and that's the area that houses the actual spinal cord. So that's the hole where the spinal cord sits. And then the body is the overall big part of the vertebrae. and it provides structure and protection to the spinal cord. So the body is kind of the whole shebang, but the spinous process is the area that we palpate, and the vertebral foramen is the hole in which the spinal cord actually sits. So moving into rigid cervical collars. So we use cervical collars to restrict motion in the C-spine. The idea behind that is our necks are very, very movable. You have many different pivot points in your neck. So if you move it when there's already injury to that area, you could aggravate that injury. So our cervical collars we put on so that we limit the movement in the cervical spine. There are tons of different manufacturers of cervical collars, so make sure that you know your equipment. Some adjust differently, some don't adjust at all, and you have to have different sized ones. Some secure differently, so once again, it's critical to know your equipment and know how to use it in your sleep pretty much. When we are putting C collars on, you have to use manual stabilization prior to and during the application. So manual stabilization is having your partner hold the head steady themselves, so holding usually right around where the ears are, so that you can hold the neck steady so it doesn't move. Doing that before and during the application just immobilizes the area while we are doing the procedure, and the procedure's whole goal is to immobilize the area. So manual stabilization is key. As far as measurement of cervical collars, you go from the shoulder to the chin. And the best way that you can do that is use your own hand and measure how many fingers, if you put your hand on the shoulder, measure how many fingers go to the chin. And that's how you should get your size for your collar. This is something that we'll show you in class how to do, of actually measuring the amount of fingers on then transferring it over to a cervical collar. A lot of these C collars do have little hooks for oxygen administration, and they do have a hole in the middle so that you can see the neck. With both of these things in place, you can usually use a C collar without compromising any sort of patient care. You can access the neck so that you can assess it and or treat the neck, and you have the hooks because it's hard to hook a nasal cannula around ears that are inside of a C collar. They kind of thought of everything to make sure that this doesn't disrupt patient care. Some general rules is once it's in place, leave it in place. This is sometimes easier said than done. Some patients get very claustrophobic or they think that's uncomfortable, so they try to take it off. So you do need to coach them through it. Some people, especially if they have altermentation, they won't accept coaching, so they're just going to keep on trying to reach and rip the collar off, or they're going to try to move their head around to try to get out of the collar. And so this is where being a good patient advocate kind of comes in place, whether that's trying to hold their arms still so that they can't reach for it. I've had a few instances where I've had altered mental patients that I tie their hands down so that they can't reach for their C collar, and it's not like I would for a combative patient where I'm really cinching it down, just a loose knot around their wrist to tie to the stretcher just to keep them from doing that. That's sometimes appropriate. Or if you have someone who's trying to squirm out of it because they feel like it's uncomfortable, it might be the best thing for the patient to take the collar off so they stop moving. Because if they're constantly squirming around to try to get out of the collar, then we're defeating our purpose of immobilizing the spine. And if they won't squirm around if you take it off, then that might be the best way to keep the spine or C-spine from moving. So yes, you should leave it in place. There are some very extenuating circumstances where you might need to take it off. The biggest thing usually is you might need to readjust the collar. Sometimes they ride up on the patient, so you look at them and the spot that their chin is supposed to be seated in is now up at their nose. So if that's the case, undo it and reapply it. And sometimes you might have to redo your measurement because you may have measured it too big. So that's usually the case of when we take it off, is just to readjust the collar. Right, moving into injuries to the skull and brain. So injuries to the head, and particularly a scalp, a lot of times they look a lot worse than they really are. And it's our job to be able to figure out how serious this actually is. So it is important for us to decide, is this an injury to just the scalp? Is this an injury to the skull? Or is this an injury to the brain? Like I said, it oftentimes looks a lot worse than it really is. That's because the scalp is incredibly vascular. It has a ton of small blood vessels. So when you get a laceration to the scalp, all these blood vessels burst and it provides a lot of bleeding. So you might show up and there's blood everywhere, and it's just from a tiny little laceration to the scalp. In terms of treatment of just scalp injuries, use direct pressure and treat as you would with any other soft tissue injury. Now, the issue with that is our steps for soft tissue injuries is direct pressure, then put a pressure dressing on the injury. Pressure dressings are great when you can secure them correctly. Skulls are not shaped normally, so it's really hard to get a pressure dressing secured to the head. So it might take a little bit of practice to actually wrap a head with a good dressing. And that's something that we'll do in class, but also do it on your own. Go to your fire department or ambulance and practice on someone, because that is a very hard thing to do. A lot of times in the field, I just do direct pressure, and you can have your patient hold the direct pressure so that you can free up your hands to do something else. But it's very difficult to get an effective pressure dressing on a scalp injury. If you suspect that there's a skull injury or brain injury where the skull is compromised, use the loose gauze instead of direct pressure. We don't want to be pushing broken pieces of skull into the brain. So a nice loose dressing. Oftentimes I don't even dress a skull injury at all, just because I don't want to accidentally push down and compromise the brain from the dressing. Typically, yes, they do bleed a lot, but it's not life-threatening bleeding to the scalp. So typically I don't want to cause further injury by trying to stop the bleed and cause an actual brain injury. So skull injuries we classify as either open or closed. Now this might be a little confusing because we just talked in musculoskeletal emergencies about how a bone that's broken is going to either be an open or closed fracture. And for a musculoskeletal term, open or closed means is the bone sticking out of the skin or not. With skull injuries, it means something a little bit different. So an open head injury is when the bones of the cranium are actually fractured. So that's when the skull is actually fractured. So skull is open. Versus a closed head injury is where the skull is fully intact. So the way that you can kind of think about this is think of open to the brain instead of open to the head. Because you can have an open injury where you can see skull, but it might still be a closed head injury. The problem with this is it's very hard for us to tell what's injured because it's hard for us to see through the skull. So you always have to assume that there is a head injury whether or not you see the actual trauma to the area. So if you have just bruising, then you have to assume that there might be some sort of head injury below that. So again, always err on the side of caution. So whether that's spine or brain or skull or anything that we're talking about today, we always have to err on the side of they probably have an injury to this area and we need to protect this area. Here is a picture of an open skull fracture, and that's because we can see straight into brain. It's, in my opinion, not the best picture to show in class because if the scalp was still closed, this could still be an open skull fracture. So it's a little misleading to show an open skull fracture where everything is open because it can still be classified as open even with the scalp being intact. So open head injuries are typically going to be a little bit worse. Typically, it's more common to have worse injuries when that's an open head injury. That's because the brain can be lacerated, punctured, or bruised by a foreign object or by pieces of skull. Any sort of laceration, puncture, or bruising to the brain is incredibly severe in terms of injury. So that's why open head injuries are very life-threatening, because you can do a lot of damage very quickly. When we have closed injuries, there are oftentimes indirect forces that cause brain injury. So you'll have the shock that is put onto the skull. So say you hit your skull off of the floor when you fall, the shock goes to the skull, but then it's transferred to the brain. And so the brain can either bounce off the skull, or it can bounce away from the skull and hit the other side. And so we see things like concussions and or cerebral contusions. So these are not usually as immediately severe as open head injuries, and that's actually what makes them dangerous, is because it's going to take a little bit of time to develop symptoms in a lot of these patients. So you might have someone who seems okay right now, but in 3-4 hours they're going to show a lot more signs and symptoms of head injury. And that's why we really shouldn't leave anyone at home after they've had some sort of head injury. We should be transporting these people to the hospital so that they can be under constant surveillance for the event that they become worse. So some terms to keep in mind: you have traumatic brain injuries, which are TBIs, and that's when the normal functioning of the brain is altered somehow. So any disruption from a traumatic cause in the normal function of the brain is technically classified as a traumatic brain injury. This most of the time is brief, but there are sometimes that there are very long-term, even lifelong complications from a TBI. So it's kind of a umbrella term that a lot of patients fall under, and there's a wide spectrum for severity of TBIs. Two things that fall under TBIs are concussions and contusions. So concussions are when the head is struck and the force is transferred to the brain. Usually in concussions you'll have a brief loss of consciousness. That's usually the telltale sign that someone might have a concussion, is a head injury where they've had a brief loss of consciousness and or loss of some sort of brain function. So they might have a loss of memory, they might have a loss of motor control for a brief moment, but typically it returns very quickly, unless if it's a very severe concussion, in which case the patient's probably going to be unconscious for the duration of patient care. Concussions should be taken seriously even with mild symptoms, and that's just because we don't know the extent of the damage that was done to the brain. So typically concussions will take to the hospital and they'll get further imaging to make sure that everything is okay. Now a contusion is a bruising. We know contusion means bruising. So it's bruising in the brain, and that's because we have a blow to the brain that is forceful enough that the blood vessels actually rupture. So that can cause bleeding into the brain, which we'll talk about in a little bit as to some issues that we see with that. But there are two terms that you need to know with contusions. You have coup and counter coup injuries. So a coup injury is the injury that occurs on the side of the blow. So if you get hit to the left side of the brain and you get an injury there, that's a coup injury. But a counter coup injury is when it occurs on the opposite side. So you get hit on, say, the left side, and all the force is transferred over to the right side, so your brain actually shifts to the right side and bounces off the right side of your skull, and that's where you have the injury, because that's where it bounces off of the skull. So knowing coup versus counter coup injuries is big, and keep that in mind that you might have an injury to the side that did not get the trauma, because you might have a counter coup injury, and those are actually relatively common. So if you see signs and symptoms indicative of a right-sided brain injury when the trauma was to the left side, it's probably because it was a counter coup injury. So going further into TBIs, lacerations are just like a normal laceration. It's like a cut to the brain, usually caused by the same forces that will cause a contusion. And then hematomas. We've talked about hematomas before in soft tissue injuries, but these are very dangerous to have happen within the brain, because hematomas, as you remember, is a significant amount of bleeding, and that's bad no matter where it is, but the big issue with it happening in the brain is brain is contained inside of your skull. Your skull does not move. So if you have a finite space or free space inside your skull, and you fill it all up with blood and you keep on bleeding, you're going to start to put pressure on your brain. And so that's what we call a usually subdural hematoma. That's one of the worst ones to have. We do have a few different other types. So you will have an epidermal hematoma or an intercerebral hematoma. So a subdural hematoma, if you remember the dura matter in your meninges, that's where we have the blood that collects between the brain and the dura matter. So that's probably the most common hematoma seen is a subdural hematoma, because you have it pretty much between the meninges and the brain. Very small space in there, so pressure will build very quickly. You could have an epidural hematoma. So this is where you have the blood collecting between the dura and the skull. So still remember your meninges, but this is on top of the dura matter instead of below the dura matter. So remember, sub is below, epi is on top. So blood collects between the dura and the skull. Then you have your intercerebral hematoma, and that's when you just have blood pooling throughout the brain matter. So all these are very bad to have happen, but subdural is typically the most common one that we see. There are other ones. You can have like a subarachnoid hematoma, relatively less common. Remember, the arachnoid matter is the middle of your meninges. So those are less common to see. So I really want you guys to nail down the subdural, epidural, and intercerebral hemorrhages or hematomas. Some of the danger with hematomas is the symptoms may not immediately appear, and that's because the bleeding has to pool first. So this is incredibly common to see in the elderly that fall and strike their head. We get called immediately because grandma fell and she needs help getting up, and we show up, she's acting normal, she might not have any complaints whatsoever, so we pick her up, she says she doesn't want to go to the hospital, we take a refusal and we leave. The danger is when she struck her head, she caused a subdural hematoma that is now actively bleeding. And especially if she's on blood thinners to where the bleeding won't stop on its own, we assessed her and she seemed fine because the bleeding hadn't gotten to a point of putting pressure on the brain. But over the course of a few hours and maybe even a few days, this bleeding has continued and continued and continued. And all of a sudden she goes to bed and she doesn't wake up because in that 8 hours that she was sleeping, she had the pressure build to the point where she can no longer regain consciousness. So this is why anyone who falls and strikes their head, particularly the elderly and especially anyone on a blood thinner, needs to go to the hospital to get a CT of their head to see if they have a hematoma forming at all. Patients still have the right to refuse care, but you need to be able to communicate with them that this is the massive risk that they run if they don't get evaluated at the hospital. And this is where it's very important to be the patient advocate, because the patient probably will have no complaints. So they'll be like, why do I need to go to the hospital when I don't have any complaints? I feel fine. You have to be able to explain to them that this is what could happen to them. And it is something that is not uncommon to see happen. This is a relatively common issue that we have to treat. So here's a little diagram of subdural versus epidural versus intercerebral. So you can see subdural, you have the dura mater, which sits right here, and then the brain, and so you have the blood between the dura mater and the brain. Epidural, remember your dura mater for your meninges is right here, and so it's on top, so it's between the skull and the dura. Both of these are putting pressure on the brain, just from different directions. Then your intercerebral hematomas, it's just going throughout the brain matter. So all of them are very bad. Most of them present the same way, and so we treat them the same way. It's just you might hear these different terms being thrown around at the hospital. But as far as our patient care goes, we treat relatively the same way and we see relatively the same symptoms. So as I just discussed in the other slides, when we have a hematoma develop, it increases intracranial pressure, which will then push on the brain. This sometimes takes a very long time to develop. It could be more rapid, but the more dangerous side is taking minutes to hours to possibly even days to develop. So when we have an increase in intracranial pressure, our blood pressure will increase to try to get more blood to the brain. The brain is saying we can't function because we're not getting perfused because it has all this pressure on it, so it triggers a blood pressure rise. The heart actually goes down. So we always teach you guys that to compensate, the heart rate actually usually goes up, but in cases of intracranial pressure rising, the heart rate might go down, and that's usually because of vagus nerve compression. Remember, our vagus nerve is one of our cranial nerves that runs from the bottom of your skull all the way down to your rectum. And when you stimulate that, its job is to slow everything down. Its job is to lower your blood pressure, lower your heart rate. It's what causes a lot of people to pass out when they get it stimulated. So a lot of times your heart rate actually goes down because of vagus nerve compression. So you're stimulating the vagus nerve. So when we have the rising blood pressure and the slowing heart rate together, which is abnormality because typically our heart rate will be going higher, this is called Cushing's reflex. And we also have something called Cushing's triad. So it's named after Dr. Cushing, who discovered the Cushing's reflex and then the triad. So Cushing's triad is bradycardia, so like we just talked about, slower heart rate, a widening pulse pressure. So a pulse pressure is the difference between your systolic and your diastolic blood pressures. So if your numbers are getting wider apart, that's a widening pulse pressure. So say a blood pressure of 100 over 20 is a wide pulse pressure versus 100 over 80 is a smaller pulse pressure. So we have bradycardia, widening pulse pressure, and then irregular respirations. We get irregular respirations because if we're compressing the brain is what controls our ability to breathe, so you're going to have wildly irregular respirations because the control center is being compressed and it can't get signals out as well. So if you see bradycardia, widening pulse pressure, and irregular respirations, that is Cushing's triad, which is indicative of increased intracranial pressure. Those are things you have to know. So you have to know Cushing's triad is associated with increased intracranial pressure, and it's bradycardia, widening pulse pressure, and irregular respirations. So talking a little bit more about compressing the brainstem and seeing respiratory pattern changes. So typically you're going to see faster breathing, so tachypnea. You can also see what's called Cheyenne-Stokes breathing. Cheyenne-Stokes breathing is relatively rare, and it's a kind of two-part thing. It has a period of fast, shallow breathing, then a period of apnea, and then you have slow, heavier breathing. So it's very, very fast and shallow, a pause, and then very deep and heavy. So that, like I said, it's a relatively rare thing, and it's very indicative of increased intracranial pressure. And then ataxic respirations is your straight up abnormal irregular breathing, so you will just have completely off the wall patterns of breathing, and it's usually associated with long periods of apnea, and it usually has increased frequency of apnea. So you'll just have really random breathing patterns that have no rhyme or reason, and you'll eventually see more apneic periods coming and having to be longer and more frequent, and it leads to apnea. Once the brain gets to this point, you're going to start seeing some posturing, and we're going to talk about that in the next slide. We have decorticate and decelebrate posturing, and like I said, we'll get into that in the next slide, so we'll wait for that. And just be aware, I've said this several times, that intracranial pressure rising can be a delayed onset. So yes, it can be immediate. This can be something, especially with a massive head trauma, you might see right away. But this is also something that can develop over time, especially with a subdural hematoma. So this is, I've been saying this all along, this is why it's critical that even if the patient doesn't have complaints or they have mild complaints, we have to treat them seriously and we have to bring them to a hospital. You can't see what you can't see. We do not have the imaging to be able to give someone with a head injury a clean bill of health. So very important that we get them to a place that does have the imaging. So decordicate and decelebrate posturing. Like I said before in the last slide, decelebrate posturing is worse. So we'll talk about decordicate first because that's considered to be better. So let's take a look at this person. So he'll be unconscious, but you see trademarks are closed hands, arms are brought to the chest, legs are internally rotated, feet are internally rotated. So if you see, he's trying to pull everything in to still protect his vital organs. He's trying to provide some sort of protection to himself. So this is where the brain is still kind of working, and it has its self-preservation going on by trying to bring your protective measures in. After you go through the decordicate phase, which some people just skip it completely, but we would be progressing worse into what's called decelebrate posturing. So decelebrate posturing, you can see his neck is arched back, his legs are straight, toes are pointed downwards, but the big thing right here, arms are straight and extended. So we've now gone from kind of trying to protect our heart and lungs to now we're just fully out and open and exposed. So we lost that self-preservation reflex. So this is the last step before you actually get to completely unresponsive and you have no motor movement whatsoever. So that's decordicate versus decelebrate posturing. And that becomes important in our next topic, which is the Glasgow Coma Scale. So Glasgow Coma Scale, it's in New York State required on every patient that you assess. So it's a mental status assessment. Most non-EMS agencies, so like hospitals and places like that, they really only use the Glasgow Coma Scale for trauma patients, and especially head trauma patients. And when you have a trauma patient, your Glasgow Coma Scale, or GCS for short, is critical to know. That's something that if you give a report on a trauma patient to a hospital, they will want to know your exact calculated GCS. So I do have a scale of it on your next slide, but some general things to keep in mind. The scores range from 3 to 15. So the higher you are, the better. So a perfect person is a 15. So me talking to you right now, I'm a 15. I'm willing to bet that you listening to this, you're a 15. But the thing to note is 3 is the minimum. There is no 0. So even a dead person has a GCS of 3. So keep that in mind. You cannot have a GCS of 0. It will always be at least 3. So the GCS assesses 3 different areas. We do eye-opening, speech, and movement. And each one of these areas has a different ranking system. And so you can get a maximum of 4 points for eye-opening, a maximum of 5 points for speech, and a maximum of 6 points for movement. And we'll show you that chart in a second. If you notice, 4, 5, and 6 add up to 15. All right, so here is the Glasgow Coma Scale list. So we'll start with eyes, okay? We'll go from best to worst. So eyes, they open spontaneously. That means the patient does it on their own. 4 points, so that's the maximum. Going down 1 step, eyes open to verbal command, speech, or shout. That'll be 3 points. Going down 1 step, eyes open to pain. 2 points. And then lastly, no eye opening, 1 point. If you think about this scale for eyes, what does this sound like to you? And that's AVPU. You're alert, verbal, painful, or unresponsive. So alert is spontaneous, verbal stimuli, painful stimuli, unresponsive. So AVPU and your eye score are pretty much the same thing. Next, we have verbal response. So again, our maximum score is 5. So oriented. So that is oriented to person, place, time, and events. If they are oriented to all those, they get 5 points. If you are confused but able to answer questions, that's 4 points. So if you're not alert to person, place, time, and event, you would fall under the confused category. A lot of patients are permanently confused, especially when they get elderly and you have some dementia set in. You might permanently be at a 4 for your verbal, which means your baseline GCS is always going to be a 14 instead of a 15. Moving down 1, you have inappropriate responses. So this would be, I say, what day of the week is it? And you reply blue. That would be an inappropriate response to that question. That's not confused, because if I say what day is it and it's Sunday and you say it's Wednesday, that would be confused. But if you say blue or pine cone, that would be an inappropriate response, but you can understand the word. So that would be 3 points. If it is incomprehensible sounds or speech, so they moan or they just go blah, 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 something like that, you would go down to 2 points. And if they do not talk at all because they're unable to talk, not they're refusing to talk, but they are unable to talk at all, that would be 1 point. Okay? So that is your verbal responses. Then going into your motor response. Again, our maximum is 6 with motor. So motor, top is obeys command for movement. I say reach your arm out, they reach their arm out. That is what we want. That is 6 points. Next would be purposeful movement to painful stimulus. So I say move your arm out, they are unable to do it, not refusing to do it, but unable to do it. Okay. Then we say we apply some sort of painful stimulus and say you pinch their lower forearm and they reach their hand to swipe your hand away from that painful stimuli. That would be purposeful movement to painful stimulus. So that'd be 5 points. Okay. Next is withdraws from pain. So the 5 points is they kind of move towards the pain to get you away from it, or to stop the pain from happening. The next one would be they kind of pull back. So they don't purposely move over to stop the painful stimulus, they just pull back from the painful stimulus. So that would be withdraws from pain. Okay. And then going one further, 3 points, we have the decorticate posturing. So we just talked about that, where they're pulled in and they're still trying to protect their vital organs, but they don't have any movement to pain. They're just pulled in. And then going down one further, 2 points, is your decelerate posturing. That's where you are extended out, and so you're not able to protect your body anymore. And then if you have no movement whatsoever, that would be 1 point. So again, GCS, this is something that unfortunately you have to memorize this whole thing. It's not as hard as you would think. And if you just think about things logically, if you remember, eyes are 4, verbal is 5, motor is 6, and then you logically think down the steps of what things should be ranked, it's usually easy to figure out. For example, should painful stimuli for eyes be above verbal stimuli? No, it shouldn't. So it's kind of a logical scale. So what happens though if we have a pediatric patient? Can a 2-year-old typically be oriented or obey commands, or can a 1-year-old obey commands? Not usually. So that's where we get to our pediatric GCS, and that's in the next slide. So looking at the pediatric GCS scale, so it's on this side compared to your adults. It's actually not that hard to remember. So eyes, if you see, eyes are exactly the same. Okay, so a baby will act with the eyes the same way an adult will. Same with motor. If you look, it's worded a little bit differently here, but motor is exactly the same. Okay, so verbal is where it comes into play, because a lot of patients under 2 years old don't have the ability to form words at baseline. So verbal, our best is coos and babbles, so they're acting like a normal baby. Next is irritable and crying without a stimulus to cry. So this is a baby that is just out of control crying for no reason. Next is you apply painful stimuli and they cry to it. Next is you apply painful stimuli and they just moan or make some noise to it. And then next is no response whatsoever for verbal. So that's really the only change, is these guys for verbal. And again, if you just think about it logically, the progression makes sense. So when we're talking about signs and symptoms of skull fractures and brain injuries, most of these shouldn't be a surprise to you at all. You know, if you have altered mentation, you see bone fragments and brain tissue, you know, that's pretty obvious that there's going to be a brain injury. But at the bottom are a few things I want to point out. First is the bruising behind the ear. Bruising behind the ear is called a battle sign. It's very rare, but for some reason the state loves to test on battle sign. So bruising behind the ear is indicative of a skull fracture where you have bleeding coming out of the brain and it forms in that little thin skin area behind the ear. It's very easy to see because the skin is very delicate there. Next is bruising under the eyes, which we refer to as raccoon eyes. Same thing, we have very, very, very thin skin there, and so if you have a skull fracture, you might have bleeding and it will be seen very easily there. And then next is the pupils unequal or non-reactive to light. Anytime that your pupils are not normal, that's indicative of abnormal brain function. Your pupils are very indicative of how your brain is doing. So if they are unequal, that usually means that you have some sort of intracranial pressure problem. And if they're non-reactive, that means that you have some sort of communication issue in your brain. Typically that means that you're going to die pretty soon if they are non-reactive to light. So those are three of, in this slide, that I kind of wanted to point out of signs and symptoms of brain injuries that you might not be as obvious as the severe pain in the head or depression to the skull. We talked about if you have blood or clear fluid coming from the ears or nose, that's indicative of cerebral spinal fluid, and we call it the halo coloring on gauze. So you'll have the drop of blood and you'll have a ring of clear fluid around it that looks like a halo. That's usually cerebral spinal fluid. We talked about Cushing's triad and hypertension and how that relates to intracranial pressure. Any sort of blurred or multiple image vision, like I said in the last slide, any vision disturbances or pupil disturbances is usually directly related to something not functioning correctly in the brain. Forceful or projectile vomiting is typical to see with a brain injury. So I mean like shooting out straight to 4 to 5 feet away from you. This will hit the back doors of your ambulance type of projectile vomiting. Any type of seizures or paralysis or disability on one side of the body, you should be highly suspicious of a brain injury. And impaired hearing or ringing in the ears, which is called tinnitus, that's could be a sign of a brain injury. Not all tinnitus is brain injury, but if you see that in conjunction with a mechanism of injury and physical injuries found consistent with head injuries, then that's something that you should be very suspicious of. I've said it a few times before, I'll say it again. You always have to be very suspicious of head injuries. Just because they're okay right now does not mean they're going to be okay a couple hours from now. So please, please, please be very, very suspicious of any sort of head injury and try to bring these patients to the hospital. Do your best to communicate the need for them to go even if they're feeling okay. We do not have the imaging to clear these patients with a good, clean bill of health. And it doesn't have to be a massive, huge car accident to cause these head injuries. Like I've said before, one of the biggest head injury patterns we see is falls in the elderly. And these are the annoying calls to go to. Grandma fell at 2 a.m. and you go and she's just like, oh, I need help up, but she hit her head on the way down. Yes, it's annoying to bring her to the hospital and turn this 10-minute lift assist call into a 2-hour transport, but it is the right thing to do for the patient. So keep that in mind. Don't become complacent with head injuries. So as far as patient care goes, relatively standard stuff. So take your standard precautions. Be very suspicious of a spinal injury. If you have enough mechanism of injury to cause a head injury, you probably torque the neck a little bit and you could have a spine injury. And if they are altered, they might not tell you that they have pain to their spine. So err on the side of caution. Most head injury patients should get a cervical collar placed. Keep your ABCs intact, especially if the ABCs are abnormal, especially with the breathing patterns. Control bleeding. Make sure the patient doesn't move. Provide emotional support if they are conscious. Do your general soft tissue injury treatment. Treat the patient for shock if they are presenting with shock. Be prepared for vomiting. So try not to lay these patients flat in case if they start to vomit. You want to be able to clear their airway quickly. So sit these patients up just a little bit, have suction ready, because vomiting is a very common sign that we see with head injuries. And remember to reassess these patients very frequently. Head injuries change things very fast. So these are patients that should have their reassessment done every 5 minutes. So if you have an impaled object in the skull or brain, very scary call to be on. Remember our general rule of thumb with impaled objects: do not remove them, stabilize them in place with a bulky dressing. What happens if the impaled object is too long to fit inside the ambulance? This could be a very long piece of rebar that may have gone into the skull. It's a very uncommon thing to occur, but it can happen. Something could be very long and impaled into the patient's head. This is where you need to take the utmost caution. The best thing to do is try to cut the impaled piece to make it fit inside of the ambulance. You are not doing the cutting though. This is where you have the fire department there, and you might actually need to have a doctor there. Most EMS response areas, especially in the Syracuse area, have a physician response team. So you can request a physician out to your scene to direct patient care and do some advanced procedures. This would be a case where that would be warranted. Some abnormal thing where you have any wrong movement could cause death to the patient because you have something impaled in their head. Have a doctor there, someone of a higher level to direct the movement, someone who knows more about the anatomy and physiology and can do the advanced procedures needed in case things go wrong. So this is a time where that might be necessary. So wrapping up head injuries. A lot of what we talked about share similar symptoms with strokes. So this is where it's important for you to do your assessment and look at your mechanism of injury versus nature of illness to decide what is this possibly being caused by. Because a lot of the symptoms that you might see with a traumatic brain injury is the exact same that you'll see with a internal hemorrhage or blood clot, which is a stroke. The big difference that you might see is strokes will always be on one side. So you'll have one affected side with the stroke. The traumatic injuries typically will affect the entire body. They might affect one side a little bit more, but it will typically involve the entire body. But again, this is where knowing your story really helps. If this is a patient that was in a massive car accident going 80 miles an hour, it's probably going to be a traumatic injury to the head. But if this was grandma who slid out of bed, may have bumped her head on the way down, but is showing all these one-sided deficits, she probably fell out of bed because she was having a stroke, and this stuff is caused by the medical side, not the trauma side. So do a good thorough assessment, get a good backstory, and follow along with what makes sense with that story. Hopefully your trauma center can also do strokes. In Syracuse, Upstate can do trauma and strokes, so that would be a safe hospital to bring them to regardless. But if your trauma center doesn't do stroke care, or you're bringing them to a stroke center that doesn't do trauma, that's where we need to make sure that we have a good guess as to what caused this, whether it's a traumatic cause or non-traumatic cause. So moving on into wounds to the neck. So injuries to the neck are very concerning, and that's because of what's housed in the neck. If you think of what's in the neck, you have your airway, you have your esophagus, you have your great blood vessels, and you have your cervical spine. Your cervical spine is responsible for most of your vital life functions. So if you have a injury to your cervical spine, you might disrupt things, motor control for like breathing, or motor control for your heart. So these are things that we can't lose. So that's why injuries to the neck are very, 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 very serious. So we're going to start by talking about the great vessels in the neck. So you have your carotid artery, which moves a ton of blood. So if you lacerate your carotid artery, you will lose a lot of blood very fast. But you also have your jugular veins. And jugular veins move a lot of blood as well, but a characteristic of it is the pressure inside of your jugular veins is usually lower than atmospheric pressure. And if we remember atmospheric pressure, air will want to go to an area of lower pressure. That's why we are able to breathe, because we create the negative pressure. When the diaphragm goes down, air will rush in. Well, if we expose our jugular vein or any other large vein to atmospheric air, it's going to want to go into that vein because it has a lower pressure than the atmosphere. So if air gets sucked into our jugular vein, will create what's called an air embolism. So that's a pocket of air flowing through our blood vessels. Even a little bit of air coming in can cause serious problems. This can cause a pulmonary air embolism. It can cause cardiac arrest. It can cause stroke-like symptoms. So this is a very serious thing to have happen. And so when we have a laceration to the neck where we think that our jugular vein may have been compromised, you need to use an occlusive dressing. Remember, occlusive dressing is a dressing that will not allow air through it. This is somewhat hard to do sometimes because you're going to have a lot of bleeding that you're going to need to control, and you have to use lots of gauze and direct pressure to control that. But on top of all that, you need to use an occlusive bandage. That way, occlusive dressing. That way air can't get sucked in and cause an air embolism. So that's very important to remember. Any sort of trauma to the neck, we need to put an occlusive dressing on the outside of it. As just discussed, our first priority is to stop the bleeding, so make sure that the bleeding has stopped, and then we need to make sure that an air embolus doesn't happen, but we need to put all the gauze on there to stop the bleeding first. It doesn't matter if we have an air embolism if we bleed out. So make sure that you stop the bleed first. And when you're doing hemorrhage control to the neck, make sure that you aren't occluding the airway. You're going to want to put a lot of pressure on a lot of these wounds because they bleed a lot. So make sure you aren't putting the pressure directly on the trachea or any other part of the airway that prevents the patient from breathing. Again, if you stop one of the vital ABC functions, it doesn't matter how well you did something else, you won't have a patient for much longer. So when you have a wound to the neck, make sure that the airway is not affected. Then you place a gloved hand over the wound, because a gloved hand will both provide pressure and occlusive dressing. You can put an occlusive dressing down, then place another dressing over top of the occlusive dressing, or you can do it the other way as well. You can do normal dressings and then put an occlusive dressing on top of it. Apply more pressure, bandage the dressing in place, and then immobilize the spine if the mechanism of injury suggests cervical injury. And this video at the bottom here is a old video of a hockey goalie that, while playing hockey in the NHL, actually had an ice skate catch his neck, and he had his carotid artery opened up, and it just shows how quickly you can bleed out from your carotid artery. And this hockey player actually lived because he had immediate assistance and trainers who knew how to treat the hemorrhage, so he was able to make a full recovery and actually went back to the ice to play again. But I do highly recommend that you look at it because it shows just how much blood flows through your carotid artery. All right, moving on into injuries to the spine. So a lot of spine or back injuries that we see don't actually come with spinal cord injury. And that's because our spinal cord and column is very well protected for the most part, because it's critical for survival. So a lot of times our back injuries that we see are injuries to the ligaments, cartilage, bones, and discs of the spinal cord, or column, sorry. So some types of spinal column injuries that we might see are fractures with or without bone displacement, dislocations, muscular strains, and disc injury, including compression. So discs are what separates all of our non-fused vertebrae. So remember, our sacrum and our coccyx are fused. So everything from the lumbar to our cervical are non-fused. And so we have these connective discs that make things all in line together. But we can injure those discs, especially in compression. So if you have a fall from a great height, for example, and you land, all that energy will compress down on your spinal column, and all these discs might compress and can become injured because of this. So like I said, a lot of these injuries won't actually cause cord damage, but the risk is always there, and so we have to take that into consideration when treating anyone with a back injury. So talking about actual spinal cord injuries, the spinal cord can either be lacerated, contused, or compressed. We'll have either a primary injury or a secondary injury. Primary injury is when the actual event happens. So you have a car accident and you overextend your spine and you cause a contusion to the spinal cord right then and there. That's a primary injury. A secondary injury happens afterwards. It's usually caused by some sort of secondary thing happening in the body, like hypoxia or shock, or the cord swelling or hypoglycemia. Something else happening that was caused by whatever trauma occurred can cause a secondary injury. They're usually actually can cause bigger or greater harm than the primary injuries. For the longest time, people thought that they were caused by damaged bone injuries, cutting the spinal cord. Usually that's not the case. It's usually from some sort of secondary thing happening, like the hypoxia or shock or swelling. So keep that in mind. We have primary injuries that happen at the impact, and then secondary injuries which happen over time due to something secondary causing the problem. So not every trauma patient has a spinal injury. That being said, we have to assess every trauma patient for a spinal injury. So this is where your good assessment skills come into play. You have to take in mind both the mechanism of injury and the patient's physical condition. So you look at their complaints, look at your full assessment. So if you're feeling step-offs when you're palpating the spine, or you're feeling some sort of deformity when you're palpating the spine, that's an indication that they might have a spinal cord injury. So take everything into account when you're making your assessment. You need to think of what happened and what you're seeing. Put those together, and if both of those say no spinal injury, then you can move on without immobilizing the spine. If one of those say possible spinal injury, then we need to take a closer look in to see, do we need to immobilize or not. So some different types of forces that can cause spinal cord injury. One of the more common ones is your flexion and extension injuries. That's your typical whiplash. So if you get into a car accident and you go forward and then back, that's a flexion and extension injury. Another one is an over-rotation, so that's where we have twisting injuries. We see that a lot with sports, especially football injuries. Next one is a compression injury. Remember, if we have a long fall and we hit the ground and everything keeps on coming down, we compress all those discs. That can happen and cause a spinal cord injury. We can also see this in a shallow water pool diving injury. If you dive into a shallow end of a pool and you hit your head, then you'll have a compression injury. Then penetrating trauma, if you have something go through your spinal cord, that will cause injury. And any improper lifting can cause cord injury. So this is why we talked about this in the first couple weeks of class. If we lift with our lower back instead of using our legs and our core, then we can cause injury from the bending. So most of these injuries, with exception of penetrating trauma, fall into the category of we are extending the spine beyond its normal range of motion. When we do that, we can very easily cause a back injury, specifically a spinal cord injury. So think of your back's normal flow of motion, and if you have an injury that extended that beyond its normal range, then we have to be highly suspicious of a spinal cord injury. So when we come to back injuries, the two sections of the back that are injured more than any other section are your cervical and lumbar vertebrae. And that's because they have no other support in your body around them. So like your thoracic vertebrae, they're supported by having the ribs come off. The ribs don't move all too much. Unless if there's a massive trauma. So your thoracic vertebrae are supported by that, and then your sacral and coccyx are all fused, and they're supported by the pelvis. So it's very rare to have a serious injury to your sacral back, relatively rare to have an injury to your thoracic back, but your lumbar and your cervical are not supported by anything. And your cervical spine is the most commonly injured part of your spine because it's has the most range of motion. Your neck has a lot more range of motion than your lumbar does because your neck can go all different directions, whereas your lumbar should only go up and down. It can go side to side a little bit, but not nearly as much as your neck does. There are a few medical conditions that make the spine more vulnerable to injury. So osteoporosis, if you remember us talking about that from earlier, in older adults, so it generally just makes the bones more brittle. They're more porous, so that can make it a lot easier to break. And then ligament laxity in pregnant women and patients with Down syndrome, so that makes your ligaments a lot more bendy, I guess is the best way to say. So they're going to allow you to turn more than normal. And so your ligaments are usually your first line of defense to stop you from overextending in a certain direction. So if you have more laxicity in it, then it won't prevent you from overextending like it should, and you can cause injury. We're going to talk about that a little bit more with pregnant women in our OBGYN presentation. So there are some certain mechanisms of injury that carry a higher risk for spinal injury. That shouldn't be anything new to you guys. So some things that we look at, and we'll talk about this a little bit more in a couple slides. Falls greater than 3 feet or more, or down more than 5 stairs. General rule of thumb for stairs is 1 step equals 1 foot generally. So if you ever have to measure how far someone fell by the amount of stairs they came down, count the number of stairs, and that's generally about 1 foot per step. Axial loading, which are compression injuries, like we said, that's very common in diving injuries or falls from great distances. High-speed motor vehicle crashes, especially with rollover or ejection of the patients. Any sort of recreational vehicle crashes, and any sort of bicycle collision. So all these are patients that you should have a high degree of suspicion for a spinal injury. Doesn't mean they will have them, you just have to be very, 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 very cautious and think that they do. Other things that we need to be looking out for mechanisms of injury: victim of a motor vehicle or motorcycle collision, a pedestrian that was struck by a vehicle, any sort of blunt injury to the spine below the clavicle, which is the neck, any sort of diving incident if they were hanging by the neck, or if they are unconscious from any sort of trauma. If they're unconscious, then absolutely immobilize the spine because they can't give you complaints, and you have to assume they're unconscious from some sort of spinal cord trauma. There are a lot of traumatic injuries out there that have a low threat of spinal injury. One of the biggest ones are penetrating traumas. For the most part, penetrating traumas, unless if it's to the spine, won't affect your spine, for the most part. Now, we all know from discussing gunshot wounds, bullets can bounce around throughout a body, so you don't know what they hit. So you could have some sort of injury to the spine from a gunshot wound, but if you have someone who is stabbed in the abdomen, for example, generally they probably won't have spinal compromise with that type of trauma. So take a look at your patient, take a look at your story, take a look at the mechanism of injury. All this goes into your decision of, do we immobilize the spine or do we not mobilize the spine? Another quick geriatric note, geriatrics can have spinal injuries from a lot less mechanism of injury. Just a simple, gentle fall from bed can cause a fracture of the spine and damage to the spinal cord in geriatrics. So have a much higher degree of suspicion for geriatric trauma versus, say, pediatric or regular aged adult trauma. They will break a lot easier than others do. Once again, mechanism of injury alone is not the only thing we look at. We need to look at the whole picture and your assessment of the patient. Pain and tenderness in the area of the spine are incredibly important findings. When you have a patient that has some sort of traumatic mechanism of injury, when you are assessing the spine, you have to palpate the spine. See if there's any deformities, see if there's any pain to the area, see if there's any tenderness to the area. Go down the entire spine. If the patient reports pain or tenderness, then we should be immobilizing the spine. If they don't, then that's one more thing that you can use in your assessment to determine yes or no for immobilizing the spine. So when we damage the spinal cord, we sever the nerve pathways that let the brain communicate with the body. So if we can't communicate with the body, we can't move the body, we can't stimulate the muscles, so we get what's called paralysis. Typically, paralysis, once we sever one area of the spinal cord, there will be paralysis from that area of sever down, because you can't get brain signals beyond wherever the sever is to the rest of the spinal cord. So you'll have a specific area of your body, and from there down, you will no longer have movement or sensation. So that's complete paralysis. There is a way to determine which vertebrae was involved based off of where the top area of paralysis is found. Those are determined by what are called dermatomes. Dermatomes is an area of the body that is controlled by a single nerve. So we'll have a picture of that in the next slide. And I don't expect you guys to know this stuff off the top of your head. Just know that dermatomes exist. So this is a chart of dermatomes, and you can see it's color coordinated, and you have the spine on your right side. And you can, if you really look close, they're all labeled like C1, C2, T4. So this shows you the level of paralysis you'd have if you had a fracture or a loss of communication at that level of the spinal cord. So again, I don't expect you guys to memorize this, but it's good to have an idea of what dermatomes are. Some other signs and symptoms that you might see with a spinal cord injury: obviously the paralysis of extremities, any sort of change in neurologic function, any pain or tenderness along the spine, impaired breathing, a priapism. So a priapism is a erection for men, and it's an erection, say, with the patient's unconscious after a traumatic event. That's indicative of a spinal cord injury. So priapism is an erection indicative of spinal cord injury. Loss of bowel or bladder control, deformities, and signs and symptoms of neurogenic shock, which we talked about extensively throughout this class, so I won't force you guys to listen to me talk about that again. All right, so this is the actual protocol from New York State about suspected spinal injuries. So the first part of this flow chart: does the patient meet adult or pediatric major trauma criteria with a blunt mechanism of injury? Not penetrating, a blunt mechanism of injury. And I've handed this sheet out to you guys on the first day of trauma of the adult pediatric major trauma criteria. We're going to revisit that in our multi-system trauma presentation. So if you want to get specifically into that, go ahead and skip to the multi-system trauma presentation. So if the answer is yes to that question, we immediately skip down all the way to spine injury should be suspected and patient should be placed on a properly fitted cervical collar and spinal movement minimized. If the answer is no, we go to this big box right here. So you have to ask, does the patient have altered mental status associated with trauma for any reason, including possible intoxication from alcohol or drugs? So GCS, less than 15. Does the patient have a complaint of neck and or spine pain or tenderness? Does the patient have weakness, tingling, numbness of the trunk or extremities at any time since the injury? Does the patient have deformity of the spine not present prior to the incident? Does the patient have painful, distracting injury or circumstances? Remember, distracting injuries are something that could be causing a lot of pain or a lot of attention for the patient, so they're not thinking about their spine. So if their bone is sticking out of their leg, they're probably not thinking about the mild little pain in their back. And then any high-risk mechanism of injury associated with unstable spinal injuries that include axial load, high-speed motorized vehicle, pedestrian or bicyclist struck, or falls greater than 3 feet or 5 steps, or the patient height. The answer is yes to any of these. Then we go to spinal immobilization. If the answer is no to all of these, then the patients can be transported without the use of a cervical collar or other means to restrict spinal motion. This is something that as a New York State EMT, you have to have this memorized. You have to know all this criteria that says yes or no to immobilizing the cervical spine. So this is a very important thing right here as a New York State practicing EMT that you have to know. If you deviate from this, you can get in a lot of trouble. You can be sued even if you don't immobilize the spine and a patient becomes worse because of that, and they met the criteria listed in here. So back in the olden days, back when I started EMS, we immobilized everyone. And by immobilize, I mean we put a C-collar on, we then put them on a backboard, and we put head blocks on either side of their head. We duct taped their head to the board, and we put 3 sets or sometimes 4 sets of seat belts and strapped them down to that board. They were not moving from that flat, rigid board. That, in my opinion, was not good patient care. Everyone had issues with it. Patients complained continually about it. So that's why spinal care has evolved since then. So modern spinal care is based off of your good assessment and the understanding that most spinal injuries are complete at the time of incident, and the biggest area of concern that we have is the cervical spine, not the entire spine anymore. So you might see someone still using the rigid spinal immobilization by using a backboard and taping the patient down to that backboard and strapping them down to the backboard. There are a lot of negative side effects to doing that. It can be very, very uncomfortable. It can cause a lot of breathing problems, especially with obese patients having all that weight sitting on their chest. And with elderly patients, you can have hypothermia because the board is cold, and you can even have pressure sores being formed. So it overall was not good care for the patients, and for the most part, I have not seen anyone use a backboard to immobilize the spine in several years, and I hope that stays that way. And anyone who's coming through class now, like you guys, you should not be using backboards for the purposes of spinal mobilization. When we immobilize the spine, we put the cervical collar on, and then we restrict the movement of the spine. So we try to put the patient on the stretcher. We secure them with all seat belts, especially the chest belts, which should be used with every patient every time, but it's an absolute mandate that you do that for anyone that has a C-collar on. And then you just restrict them from moving. So try not to get them to sit up, try not to get them to stand up. When you get to the hospital, transfer them with the sheet that's on the stretcher so that they don't have to move. So we're just restricting the movement of the spine until they're evaluated further. A lot better than using a backboard. So the basic principle of pre-hospital spinal care is, like I just discussed in the last slide, limiting the movement of the entire spine. So that's why we use the C-collar, and that's why we try to limit the patient's movements. So the whole goal there is if there is an unstable fracture, we aren't moving it around and causing secondary cord damage by movement of the spinal column. So you do have three centers of mass in the body. You have your head, you have your shoulders, and you have your pelvis. That's where a lot of our mass is carried. When all three of those can't move anymore, the spine generally remains stable. So keep that in mind when we are trying to restrict spinal movement. If you have the pelvis laying down on your stretcher, it's not going to move much. If you have your shoulders laying back on the stretcher, they aren't going to move much. If you have your C-collar on, it's going to make so the head doesn't move around much. So that's our whole goal, is try to make those three centers of mass not move often. Keep in mind that the spine does have a S-shaped curve. It's not a flat straight line, and that's why patients didn't fit on these flat backboards very well. They were not the shape of a human spine. Flat does not fit with S very well. So that's why we are moving to the spinal motion restriction, because if we're on a stretcher, the stretcher conforms to the back a little bit better. It's a lot better than the backboard that was just straight. As I mentioned earlier, manual stabilization of the head is our first step in spinal motion restriction. Once you identify the need to restrict the motion of the spine, manual stabilization should be held until the patient has a C-collar in place and is in their final resting place, which is your stretcher. So we do it by putting our hands on either side of the patient's head. You try to stop movement of the head and maintain an inline neutral position. If the head is out of its inline neutral position, then you can move it carefully and slowly to be in line. Again, we need to properly size our collars. And then once the patient is on the stretcher with the C-collar on, you remove the manual stabilization and you secure them with all seat belts. In cases of extreme movement where the patient's not listening to you, or they might not have any motor control because they're unconscious for some reason, or they have some reason where they can't hold their head still, you can use head blocks. Those are pretty much two big foam pads. You put it on either side of the patient's head, and then you're going to have to tape the blocks and the head to the stretcher. Again, these are more of extreme case scenarios. After you've restricted the motion of the spine, then you establish your baseline for sensory, motor, and circulatory functions in all the extremities. So I just went on and on about how terrible backboards are. There is a reason why we still carry them on the ambulance. They have their use in some situations. We can use them to move the patient on scene in certain situations. They are helpful because you can seatbelt them to the backboard, and they have multiple handles for multiple people to carry. They're also nice for a large splint. If the patient has multiple traumatic injuries, if you put them on the backboard, generally they won't move much, so it's a catch-all splint. Generally, these are patients that are going to be unconscious, though, if they are that bad that they need a backboard to splint their entire body. We use a backboard for a patient that will possibly need CPR, and that's because a backboard is a nice hard surface for us to compress on, versus a stretcher is a squishy surface, which is not the best for CPR. And if you have the patient on a backboard and you can't get them off without causing excessive movements, then you can keep them on the backboard for transport, but we do generally try to get the patients off of the backboard after we've moved them onto the stretcher. One great thing that is very well underutilized, and we went over it in lifting and moving, are scoop stretchers. Scoop stretchers are becoming more popular. It's still very well underutilized, but that's where you can come underneath both sides of the patient and scoop them off the ground, bring them to the stretcher, and then once they're on the stretcher, you undo the scoop stretcher, and you don't have to move the patient off of the backboard, which causes more movement. So they are very nice for suspected spinal injuries, to where the patient doesn't have to lay on a backboard, but we can effectively move them without causing movement of the patient. So we've talked about vacuum mattresses a little bit in this course. It's relatively rare for an agency to have one, so if your agency does have one, please train a lot more on it. I'll just give you the basic rundown. They are a mattress-like material, the comic canvas you can put underneath the patient. You then inflate it, and it will conform to the patient, which is very nice because it will fill all the voids in the patient. So much more comfortable. And then you can also kind of slide the patient on the mattress to your stretcher. They can leak air and lose rigidity over time, and they can take heat away from the patient. So those are the basic bullet points of vacuum mattresses. Again, if your agency carries one, I highly recommend that you get individual training from your agency's training officer about how to use them. So if you have a seated patient, most of our seated patients are patients that we're going to be taking out of vehicles. We have two basic options for spinal motion restriction. First is you put a long backboard under the patient's buttocks and you lower the patient to the board in a supine position. This is a lot easier to do than to describe. So if you want me to show you how to do this, we can do this in class. A lot easier to actually see it done than to have me describe it to you. Second way you can do it is you can have the patient self-extricate by standing up and then sitting down immediately on the ambulance stretcher. If they do this, you should have a C-collar on the patient and you should hold manual stabilization as they do it. You should try to make the movement nice and smooth and limit the motion of the spine while you do it. Back when I first got my EMT, there's something called a KED vest, a Kendrick extrication device, that was used for seated patients. Those are no longer recommended in the field. We did go over it once in class. They are still required to carry on an ambulance in New York State right now, but I have not used one in years and years and years. There's very few times I could ever see that ever being something beneficial to use, and we do not use it for spinal motion restriction anymore. If you do have a patient that you need to put onto a backboard, you log roll them to the backboard. So you have one person at the head, two people at the body. You roll the person in one direction, you slide the backboard underneath them, you then roll them back onto the backboard. You then, in a coordinated effort, go down into one side, then up into one side. The person at the head is the one who controls the movements. Try to pad the voids between the board and the head and torso. Remember, our body is not flat, the board is, so try to put some like blankets or sheets or towels to pad those voids, otherwise it's going to cause a lot of pain. You secure the head last. Use the head blocks, which are foam filled cushions, to do head immobilization. And then once they're on the board, if they are pregnant, tilt them to the left. We'll discuss that in OBGYN emergencies of why we need to keep pregnant patients off of the straight supine position. And then you put straps across the upper chest, pelvis, and thighs. If you have a standing patient, then apply a cervical collar and have the patient carefully sit down on the stretcher, and then secure them to the stretcher with all seatbelts in a semi-Fowler position. So there are certain instances where you have a patient with a spinal injury that is wearing a helmet, such as a motorcycle helmet or a football helmet. If you need to take care of the face, neck, or spine, or do airway management or resuscitation, you should take the helmet off. If you do not need to do any of those things, you can leave the helmet on if needed, or if you prefer to, just lift any shields or guards so that you can access the patient. If the airway is intact, do not try to remove a helmet if it causes pain or if the helmet is difficult to remove. Best way to remove a helmet is to have one person slide their hands from the neck up and holding the head, so you kind of slide in underneath the helmet, and while they're holding manual stabilization that way, the second person will gently remove the helmet off. So it is a two-person process to properly remove a helmet, but if it causes pain and there is no airway obstruction, then try to keep the helmet in place. Other times when you should leave a helmet in place as long as your airway is intact. If it fits snugly, allowing little or no movement. If there's absolutely no airway or breathing issues, removing would cause further injury. You can't do proper spinal mobilization with the helmet in place, and it does not interfere with the EMT's ability to assess airway or breathing. Notice airway and breathing come up quite a bit in these two slides. If their airway is intact, generally we can leave the helmet on. A lot of it comes to patient comfort and patient requests. But if you try removing it and it causes any pain, then stop removing it. Obviously, if you do have the hindrance of treating the airway, or if it's improperly fitted, or it interferes with mobilization, or the patient's in cardiac arrest, go ahead and take the helmet off. If there is an athlete wearing shoulder pads and a helmet, either take both off or none of them off. So if you take the helmet off, you have to take the shoulder pads off, because shoulder pads knock off the natural neutral position. So that's compensated by the helmet if the helmet's on, but if you take the helmet off, you should take the shoulder pads off to maintain a neutral position. Moving on to a little bit of chapter review. The two main divisions of the nervous system are the central nervous system and the peripheral nervous system. You should maintain a high index of suspicion for head or spine injury whenever there is a relevant mechanism of injury. You must provide spinal motion restriction before beginning any other patient care when the head or spine injury is suspected. Altered mental status is an early and important indicator of head injury. Monitor and document your patient's mental status throughout the call. A traumatic brain injury is any injury that disrupts function of the brain and may include anything from a slight concussion to severe hematoma. Always secure the torso to the backboard before the head. You are treating a patient with a head injury. He has an altered mental status and a significant mechanism of injury to the head. Your partner thinks you should hyperventilate. When should you hyperventilate? What are signs and symptoms that would indicate this is necessary? So for the most part, at BLS care, we should never hyperventilate our patients. There is one slight time when an ALS provider might ask you to hyperventilate a patient, and that is before they do an advanced airway procedure. But we do not want to hyperventilate patients. We've talked about this several times in airway management. Hyperventilation causes a lot of problems. So if a partner is asking you to hyperventilate just because of the patient's not doing well, remind them of your basic airway management skills. That brings us to the end of this chapter. I know there was a lot to discuss. We covered a lot of it pretty darn fast, and head, neck, and back trauma is a huge area of trauma, both in what we test on and in what you actually see in real life. This is what hangs a lot of providers up, is improper care of the spine. So make sure that you know a lot of the stuff that we talked about, especially the indications to immobilize. So until next time.